Our next speaker is a veteran of the United States Air Force. He began his career in '87 with the Health Services in Bethesda, Maryland. He has an undergraduate degree in chemistry from Southern Mississippi University. He is a board-certified psychiatrist and a board-certified forensic psychiatrist. He has run the psychiatric service for the United States Air Force. He has been the clinical director of Forensic Services Division at Central State Hospital in Milledgeville, Georgia, where he supervised the management of over 180 medium and maximum security inpatient psychiatric clients. He has a Master of Business Administration from the University of Louisville, and he has served on the faculty of the University of California, Davis, University of Texas Health Sciences Center at San Antonio, Mercer University, Emory University, the University of Louisville. He is a distinguished fellow of the American Psychiatric Association, and he has served as the president of the Kentucky Psychiatric Medical Association. Welcome, if you would, Dr. David Walker.
Okay, well, thank you for that introduction. I'm here today to really talk about I think success, certainly the challenges and still remaining opportunities that we have in Louisville at our VA. We're the Robley Rex VA Medical Center. And what happened was in Kentucky, for the first part of the life of the state prescription drug monitoring program, it was voluntary. And the VA nationally prohibited any of its physicians from actually looking at any state prescription drug monitoring program. So in essence, we really didn't know a whole lot of what was going on outside our system, and people outside our system really didn't know what was going on inside our system. House Bill 1 was passed, and that is the law that changed the state prescription drug monitoring program in Kentucky. It's also known as ETSU. It's for the electronic state system that is the prescription drug monitoring system. And what I'm going to do is go over little pieces of the law and the regulations, the work we did with it, and this is really an operational talk in some respects. Let me say that the year preceding the implementation of the changes in CASPR versus the year now that we have post-CASPR, where the Louisville VA has been actually participating, we have seen a 10.2% decrease in the total number of controlled substance prescriptions. Now, our system is not only in Louisville. We go north into Indiana. We go up towards about halfway to Cincinnati, and we go down not only to Fort Knox, but a little bit west and south of that to Grayson County. So we have 8 different clinics. We serve approximately 42,000 patients. And we have about 450 total physicians, many of them part-time, associated with the University of Louisville, and the rest full-time with us. So what you're going to see is me talking, and here is me talking about what was basically herding cats. So that was the system that we were tasked with, that I was able to lead in the implementation. So with that, so the House Bill 1, or the CASPR law, if you look at it, It basically is the law that really changed the rules. First, it became mandatory. What happened and why the VA was finally able to participate is that in Kentucky, its state prescription drug monitoring program belongs to the Attorney General, the law enforcement side of the house. In most states, it belongs to the Department of Health. And so the decision was made that we were able to, under a law enforcement exception, participate with the system. Okay. Now, the other thing is that if you are licensed in Kentucky, you have to register. Again, prior it was voluntary. You could do it. This changed. This was a little bit of a challenge for us in the VA system because in the VA system, you have to have a license that's in good standing. That license does not have to be in the state where your facility is. And so it's like in the military. In the military, you have to have a medical license. In the VA, you have to have a medical license. The majority of our physicians are licensed in Kentucky, and so that wasn't as much of an issue. But we border Indiana, it's the other side of the Louisville there, the Ohio River is Indiana. And so some of our physicians were licensed in Indiana, which certainly has a different program. The education piece, this was the next change. What the law requires that each prescriber have to have a percentage of their required hours of medical education be education that has been actually approved by the Board of Medicine of Kentucky, talking about substance abuse, about the CASPER program, substance abuse treatment, or pain management. And so that was a new change. You heard earlier about the issue of the lack of, or the real paucity of medical education in substance abuse and chronic pain. And so now this is a requirement. What we did was to develop actually training and to find additional training that was available electronically through a computer system that any physician in the VA system can access regardless of where they're located, specific to treating chronic pain. In addition, I'm also a medical review officer, which means I'm a drug tester, and so I'm the one that actually gets the results for our whole facility, and then using the Department of Health and Human Services guidelines, I'm the one that works through that to see if it's actually reported as a positive or not. But I developed and gave training on drug testing, because drug testing is not as straightforward as one might necessarily think. For this, I don't have any, I have slides, but they're not in this deck on drug testing, because that itself is an hour plus talk. But if anybody here is interested in those, certainly let me know, and you can have them. Okay. The other thing in Kentucky is that although there's been a reputation of the medical board being real strict, they had actually found that some folks weren't reporting things, and actually some physicians that had been convicted felons were practicing. So the rules were changed around that. And then lastly, in Kentucky, if you have a board sanction from another state, the Kentucky board actually has to use that and then implement a similar sanction. So this is the part that was the challenge for us. What happened was the law developed standards, and then it then required each board, so the Board of Medicine, the Board of Pharmacy, the Board of Nursing, each board then had to promulgate its own regulations. The challenge for us was the Medicine Board came out with emergency regulations timely, i.e., I think 2 days before it was to go into effect. And So that itself was also a challenge. And then the regulations actually significantly expanded the law. But what happened is that some exceptions were defined, and I'll talk a little bit about that. There's some cases where I think most, if not all of us, could agree that you need to give the medicine and not be, looking at a Casper. So, somebody comes in from a motor vehicle accident, they've got a bone sticking out. It doesn't really matter what their Casper looks like. You're going to have to treat them so you can reset that. So there's some exceptions, certainly. Or somebody who has, cancer that's now spread to multiple areas in their back, and those bones are now fracturing. You're going to treat that person. And so there are some exceptions that we'll talk about that were defined. The documentation requirement, in our system, we were very fortunate because we have an electronic health record, and the VA's had it for over a decade. And so for us, this was not an issue. I have a way of knowing that if a patient has an appointment and they show, but the physician doesn't complete the documentation, I actually know the next day, because we run a report, and it's called an open encounter. So if somebody's seeing and not documenting, we can find out and quickly put a stop to that. This certainly could be an issue in smaller practices or practices that don't have electronic health records. The next issue here for the standards that talked about for pain. Now, not all controlled substances are for pain. If anyone in here has a child that has attention deficit disorder, they might be getting a stimulant. Certain psychiatric conditions certainly can be treated with benzodiazepines. That's not pain. And so the initial focus was on pain, and then that was broadened, and I'll speak a little bit about that. And then this issue of, do you treat a, quote, short-term treatment course different than a chronic or long-term? And, if before Casper you ask a clinician, well, what's chronic treatment? Somebody might say greater than 3 months or greater than 6 months, or, well, what's, not chronic treatment? And so Casper actually helped define that. It's 90 days. So anything less than 90 days is not long-term, and anything more than 90 days is. Next is an emergency room. We all here certainly have seen people wanting to bypass physician offices to go to emergency rooms. So we implemented a system so that we didn't have our patients actually trying to do that and go to the emergency room. Okay. These are some of the exceptions briefly. If somebody's in a hospice program, officially in a hospice program, so end-of-life care, those are exempt. You won't see records looking at Casper. If you were treating cancer pain, and it has to be cancer pain, it cannot be the cancer patient who happens to have chronic back pain they've had for years. And so we've had to, that takes an education piece and defining that out, certainly. Okay. And then the single test. If somebody has agoraphobia and you're going to put them in a big MRI machine, or if you're going to sedate somebody before you do a procedure, that certainly was an exception. Now, one of the things that would, the criticisms from, and things found in the pill mills in Florida and other areas, was that they'd either have an MRI or CAT scan machine on site. If you do a test, you'll find something on there that might look a little abnormal. We use that as the justification, and then you've got, well, see, they had an abnormal MRI, but probably a third of us in this room, if we had an MRI, you could probably find something that might be a little abnormal. Doesn't mean it's clinically relevant. And so now we have a system where, because of the law, you have to have a history and physical. Now, it can be a focused physical. So if somebody has a fractured arm, you're not going to find a genitalia examination. So it will be a focused exam, but there has to be an exam, a history, and then you have to come up with what's called a treatment plan. Medicine in general has shifted its focus to what's called patient-centered care, and that is, instead of me, the doctor, telling you what is wrong with you and what you need to do and what your problems are, it's you telling me, what do you think's wrong with you? What's important? What helps you be successful? What prevents you from being successful related to your medical condition? So, example, if you have diabetes, I can say, your hemoglobin A1C is greater than 9, it has to be less. Well, you might say, I don't really care about that. I want to be able to see my grandkids graduate from high school. So then you focus on what's important to the patient. So you look at problems and a treatment plan associated with that, and that's now a requirement. If you looked at many medical records some years ago, you wouldn't see that. You would see, pain, which is not a diagnosis, it's a symptom, and then prescribe a medication. Now you should see what's the diagnosis, what supports it via the physical, what's the plan, and then how are you going to measure it and get there. So those are the differences now. The risk and benefits and patient education, what we came up with was we through our electronic health record, we have a specific note for an initiation of a controlled substance, a different note for a continuation, i.e. chronic use. We have an electronic consent that the person has to sign. We have opioid treatment agreements. And so if you come in and take a look at one of our patients' records, these are the kind of things that you would see in our system. Now, they have to be filled out, they have to be done, and through education and through working with all the clinicians, we now have certainly been able to implement that. But you have to provide treatment. And so the year before we instituted our CASPR journey versus the year after, we now have a little over a year after, our number of outpatient substance abuse evaluations, i.e. people coming in to be seen and are seen and evaluated for substance abuse treatment, that number has increased 30%. Part of our planning was, one, at all 8 of our clinics and in our hospital, we have the ability for substance abuse evaluations and treatment. We even use the telehealth equipment to provide certain treatments if you're at one of our rural CBOCs for groups. And so you may not have enough people in one location, but through technology you can do groups. So we have done that, and we have seen an increase in the number of people being evaluated for substance abuse, because that's important. Okay. Quarterly, you have to look at the CASPR every 90 days. Now, in our system, initially, okay, am I going to have to see the patient every 90 days if the patient's stable, they're on a chronic use? Now you have to see them at least once a year, but you have to review that CASPR every 90 days. And then you have to show that you've reviewed the actual treatment plan, that you update it, and that you've considered, other things, not just the use of the controlled substance to treat the issue. Okay. So for us, we actually developed these notes and templates, made them such that they were easy to use. Some can automatically populate with information. Other information can be checked and or typed in. This is important because I have about 35 primary care doctors, and they each see 70 patients a week. And so you can imagine the amount of paperwork, although it's on a computer. And we have to be careful in our system, there's something called the one-click mentality. You add something else, and it's just one click. Well, it might not be just one click. It might be several clicks, getting out of this note, going into another one, then doing a different note, then doing this one. And so what happens is one resistance is that you have to make it more user-friendly. And in electronics and medical records, oftentimes clinicians aren't involved in that process, only administrators are, and then you end up with something that would be very cumbersome. We've fortunately been able to, I think, work around that. Okay. And then again, I mentioned the training. Any provider that actually prescribes controlled substances in our system has to have the training. And you can do it from your computer at home, and you can do it. Anyone can do it in the VA system, and it's AMA sanctioned Category 1 continuing medical education. So it actually counts toward their licensure. To do a CASPR, you have to enter some information, and so we had to work operationally about getting people to do those. Name, date, social, their address. And so if I'm a clerk and I'm checking in patients for 7 doctors, each seeing 15 patients today, you can see that can be an obstacle, and we've worked around that with, we can look through our pharmacy package and see who is on a current medicine or has been on one within the last 90 days that probably needs a CASPR, and then we have a system to get those the day before. And then we also have a way to take the information in CASPR and actually upload it into our electronic medical record. Prior to the change in the CASPR law, you couldn't give the patient a CASPR. And when they changed the law, they hadn't yet updated the system. So then the law said you could give it, but the CASPR report said it was a felony if you gave it. So that was something we had to work out with the folks at CASPR to get that done. Lab costs. Okay, we have 42,000 patients. I'd like for somebody to tell me how much you think we spend a month on drug tests. Somebody in the middle here. What do you think we spend a month to support 42,000 patients? Any guess? I'm sorry? No, it's actually, initially, it was very high because they were testing everybody every time. And so at one point, it was going to be close to $600,000 a year just on lab tests. Now it has finally settled down. In our system, we're spending about $23,000 a month on drug tests that we were not spending before CASPR. We were doing different drug tests. Now, why is that important? In our system, the old drug tests we were doing would pick up naturally occurring narcotics. Some of you in here have heard semi-synthetic, synthetic, natural narcotics. The natural narcotics are the ones that occur naturally in nature. The synthetics are ones that are completely man-made, so methadone is synthetic. And the ones in the middle, the semi-synthetics, are the ones that you've all heard the most about, your oxycodones and hydrocodones and those. Our screen didn't pick those up. So the drug screen was real cheap, but it was useless unless you were giving somebody morphine. And so we had to specifically work on this. These type tests have to be done using mass spec gas chromatography, and the machine alone costs about $80,000 to $90,000. Plus, you have to hire 2 staff to run it. So we actually send ours through a contract. They should go to North Carolina, and they're sent every day to LabCorp. I don't own stock in LabCorp. It's just who the contract is with. But they used to run them once a week. Now they get so many from us and the other hospitals in the area, they run them every day. So, okay. The interstate issues, when we have 2 clinics in Indiana. For those of you that have been in our city, you cross one of 2, hopefully soon to be 3 bridges, you're in Indiana. And so what about patients going over to Indiana? House Bill 1 basically set in motion the ability for Kentucky to work with other states and their prescription drug monitoring programs with priority on the contiguous states. And now, if I'm writing Suboxone for a patient, I can actually, through Casper, see the Indiana data. And so that's certainly very helpful for us. And the requirements on the time, whenever, most people don't like change. I don't think physicians are exempt from that, certainly. And this did and is, I think, in a good way, causing a change in practice. But that also takes a learning curve, adjusting to the time, and that's something that we had to work with our providers. As you can imagine, we had some patients that maybe one of the things we're judged on is our surveys and how feedback and how positive we're getting. So let's just say some of our feedback didn't go up with certain patients, but we call them a patient advocate, started getting a lot of complaints about so-and-so, doctor so-and-so won't prescribe this, and basically, as the deputy chief of staff, I'm not going to order somebody to prescribe something. They've got to make that clinical decision. They've got to follow these rules, and basically, their license is on the line. And so we've backed our physicians who have set limits, and the complaints are decreasing because the patients are realizing you can't. Okay, I want a new doctor. Well, that doesn't work because we communicate. Oh, I'll go to the ER. Well, we've been monitoring that. Our ER is not going to write you for a prescription. They're going to tell you to follow up with your primary care doctor. So it really takes a system approach, or patients will find a workaround. The thing here is that, and this is the part that has concerned me, is the pendulum of, well, I won't prescribe them then. I won't have to jump through all these hoops, so I won't prescribe. Well, that's to me not appropriate. And we've had some providers where we've had to educate and talk with them. The other thing is, as you know, in the field that we're all in, that you have to work with patients. And so we will have patients that will do well and then they'll relapse. You have to set limits with them. You have to refer them or require substance abuse treatment. But it doesn't mean they can never receive particular types of treatment depending upon their medical need. And so the issue of, well, I won't prescribe it, or you get one strike and you're out forever, those have been, I think, the things that that requires clinical leadership working with the prescribers, because prescribers are afraid that I'll lose my medical license if I do this. And the law does say, if somebody has a dirty Casper, whatever term you want to use, it doesn't mean you cannot, but it means you have to justify it. And I've had cases where the Casper's not accurate. I mean, I've had Caspers say the person is 80 years old, and I look at their VA ID, and they're 30. And I know that it's the parent, it's not the patient. The pharmacy that uploaded it changed it by mistake, and I'll call that pharmacy. And we had one where 3 different patients' information was on a single patient's Casper. Well, that didn't make sense. So we document that and move forward. Passing the buck, so to speak. I'm a specialist, I'm an orthopedist. Most people come to an orthopedist because they break a bone. Is an orthopedist going to say, well, okay, I can put you in a cast, but you're going to have to see somebody else to get your pain management. So it kind of sets up this, primary care is going to handle everything. And in our system, we do not encourage or want most of our specialists to do long-term treatment of pain. Instead, we want them to work as a consultant with the primary care doc, and the primary care doc actually manage it. And so we have worked with that, and that's something that you can imagine when this first went into effect, the number of patients calling in for appointments, certainly. So it's a good thing, I think, overall, because our total number of prescriptions has decreased. Our use of our substance abuse treatment has increased, and that's what we would expect if this program is going to really make a system that carries for 42,000 people to implement and do what's right for treating pain and other conditions with controlled substances. This uncomfortable working, I'd like to give an example. I'm a veteran. I was in from '87 to 2003. So the Department of Defense, released a report that from about 2002, I think it was 2000 to 2007, they had about a 3 to 4-fold increase in the number of prescriptions that were written for controlled substances. Most people in our system have been deployed 3 times, not 1, and most deployments are at least a year, and a full gear can be 80 plus pounds. So you wear 80 plus pounds for the majority of 1, 2, or 3 years. You can expect that some of your joints are going to ache. You've been exposed to blasts. In a theater, it is survival. And so we have seen a lot of folks come back that are addicted to narcotics, not to heroin, even though I know in Afghanistan opium is there, instead to prescriptions. So imagine we talk about this difficult conversation or talking about a drug screen result. Veteran has a Purple Heart, has lost part of a limb, is on 200 milligrams a day of methadone. And for those of you that aren't prescribers, you're going to know that's still a lot of methadone. Is running out early and showing up early for prescriptions. That's not an easy conversation to have with that patient. And so it does take a system approach. We have mental health embedded in primary care that can help with this. We have substance abuse evaluators and treaters in every clinic associated, plus the hospital. And this is something that is easier said than done, without a doubt. But this is the part of practicing medicine that I think is extremely important. And now, with the system that we have in place, we can actually provide the help that the person needs, assuming they're ready for it. And those of you that know the stages, De Clemente's stages of accepting that someone has a problem, most people don't come into that, with that stage of, I have a problem, I'm ready to go. Instead, it's, you don't understand, I have a prescription, I served, the doctor's been giving it to me, that type of conversation. But we have those in our system, and we have the sources to treat the veterans. And this we've spoken to. This is really looking at, you've got to be able to provide treatment for the state systems. We work with the state of Kentucky They have a identified veteran or person knowledgeable about the veteran benefits in every mental health clinic in the counties in Kentucky to help for referrals for veterans. But if you're not a veteran, these kind of services are not always available in the areas where they're needed. And I think that's one of the reasons that why we're here. I know when we had the privilege a couple of years ago when Gil Kulikowski came in, and I said, I have trouble pronouncing your name, and he said, it's Gil. But he actually toured our treatment facility there in Louisville, and we're fortunate, certainly in the VA, to the services we have to provide. So in closing, let me just say that what we did was we took a population where we served 42,000 patients, and we were able to implement the prescription state monitoring system. We've had a 10.2% decrease in total controlled prescriptions written since this, and a 30% increase in actually substance abuse evaluations. We are a Suboxone prescriber. We are not a methadone clinic. Our prescription drugs, the prescriptions themselves, are uploaded into the Kentucky CASPR system, and I think we've been able to successfully implement this leg of the program, and certainly be willing to take any questions that folks may have. Yes?
How do you feel about Suboxone? Is it a temporary solution, long-term solution?
Well, let me say, I am a Suboxone prescriber. I think that it definitely has a place in treatment. We do not use Subutex, which is buprenorphine only. We use Suboxone that also has the naltrexone in it. The naltrexone would, if a person is using a narcotic, they're addicted, they're using a narcotic, and you give them a Suboxone, they will go into withdrawal. They will be miserable. And so they have to be in withdrawal before they take it. And so I think it's a drug that when it's part of a treatment program, so not just here's your prescription, next, you still have to closely monitor. We actually, every time I see you, I not only check for Suboxone, but I check for the metabolite in your urine to make sure you've actually been taking it. We use an evidence-based approach to get you to the right dose first. It's FDA approved up to 32 milligrams a day. Our average patient is on about 16. So probably lower dose maybe than some areas. And we will require active involvement with substance abuse treatment counseling. The patients I have that are on Suboxone that have slipped will say that basically they don't get high on Suboxone, that it's a bridge, and that usually it's those patients that weren't really active in the psychological treatment piece of it. But I think it's a good medicine. I think it has its place. I think that I'll say chronic, greater than 90 days. When I get somebody on Suboxone, their life is usually pretty messed up. They may still have a partner or spouse. They may not. What is their goal? Is their goal to try to salvage their marriage? Is their goal to become a college student, to get back into the workforce? And my approach is, I need to get you back to where that goal is as long as you work with me. And then we can look at a very slow taper. And so that's how we approach it in our system. We have 3 Suboxone prescribers. I don't think it's a drug for abuse. I think it's a drug that when people can't afford it, it's a bridge. So we have been twice in the last year and a half. The DEA has come to us and done one of their unannounced inspections. And I think it's the easiest ones they ever do because our pharmacy deals with it. We don't actually deal with it. So, but I think it's a good drug. Okay, any other questions? Yes.
Listen to you talk about Suboxone there, and you know, see it as a good drug, and as a taper, you know, you're going to taper most of your patients off. Patients that are victims of trauma, say women that are victims of sexual, physical, or emotional abuse, do you treat that in combination with the taper down, or do you simply bring them in, taper them down, get them off, and send them on their way?
Oh, I don't think you can treat Suboxone in a vacuum. I think you have to have the patient stable. So if the patient has, whether it's a PTSD or an anxiety disorder or personality disorder, treating of that has to be part of the treatment. What we will do is I will focus on the Suboxone piece, and the counselors that work with me will focus on substance abuse. We have a clinician who she works with PTSD victims who also have substance abuse. So she would actually do that aspect of the work, and then we try to graduate the patients back out to a clinic, and we would make sure that that clinic is fully aware and capable to manage everything except the Suboxone. We still have to manage that. Yeah. I'm sorry? Yes, I'll be around to answer other questions. I'm also going to be on a panel. And again, I'm David Walker. My email is david.walker6@va.gov. And I'd be more than happy to take any other questions. All right, thanks.
Thank you.
Thank you.
Thank you.